Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. This is first part of the series Tachyarrhythmias and topic for this video is supraventricular tachycardia. Tachyarrhythmias are classified depending on QRS duration. In narrow complex tachycardias, QRS duration is less than 120 milliseconds, while in wide complex tachycardia, QRS duration is more than 120 milliseconds. Types of narrow complex tachycardias are sinus tachycardia, atrial tachycardia, AV-nodal re-entry tachycardia or AVNRT, atrioventricular re-entry tachycardia or AVRT, atrial flutter, atrial fibrillation, and multifocal atrial tachycardia. Out of these, first four are covered in part 1. Sinus tachycardia is physiological. Rest 3, that is atrial tachycardia, AVNRT and AVRT, were combinedly termed as paroxysmal supraventricular tachycardia or PSVT in past. Sinus tachycardia can be physiological and can be induced by sympathetic overactivity like in exercise, anxiety, etc. It can be present as a response to pathological condition like fever, hypoxia, pain, hypotension, etc. And it subsides with treatment of underlying condition. Atrial tachycardia is caused due to ectopic focus of increased automaticity, which takes over SA node as pacemaker. Normally, atrial depolarization spreads from SA node, but in presence of ectopic focus, direction of spread of depolarization as well as direction of vector changes depending on anatomical location of ectopic focus. Hence, P-wave morphology is different from normal rhythm. Automaticity of ectopic focus is usually induced by exercise. Atrial tachycardia shows warm-up and cool-down phenomenon. RP interval is greater than PR interval in atrial tachycardia. I know you didn't understand the last 2 points, but don't worry, they are explained later in this video. As you can see in this strip, tachycardia started with a premature P wave, which have different morphology than normal P wave. Heart rate slowly increases, which is also called as warm-up phenomenon. Ultimately, atrial tachycardia achieve heart rate between 150 to 200 beats per minute. While termination of this rhythm, heart rate slows down gradually to change to sinus rhythm. This is called as cool-down phenomenon. In this ECG, RR interval is 9 small boxes long. Hence, heart rate is approximately 167 beats per minute. In cases of atrial tachycardia, it is difficult to record initiation of abnormal rhythm. This ECG is also showing only one morphology of P wave. Here, RP interval, which is between start of QRS complex to start of P wave, is greater than PR interval. So, this ECG represents atrial tachycardia. For treatment of atrial tachycardia, beta blockers like IV metoprolol or calcium channel blockers like diltiazem are used to control ventricular rate. Antiarrhythmic like amiodarone can be used in cases not responding to above therapy. DC cardioversion is indicated if associated with hypotension. AV-nodal re-entry tachycardia is a narrow complex tachycardia where abnormal impulse generation occurs in AV node by the process of re-entry. There are some prerequisites for re-entry to occur, like anatomical abnormality in AV node in the form of dual conduction tract instead of one, different conduction speed in both the tract, and different refractory period in both the tracts. Let's understand pathophysiology of re-entry. Normally, there is only one conduction tract in AV node, which is denoted by dotted area here. Normally, AV node receives impulse from atria via internodal bundles. Conduct this impulse slowly and pass it on to ventricles via bundle of His. When there are two conduction tracts in AV node, normal sinus impulse reaches AV node, then impulse is conducted through both the tracts simultaneously to other end, and impulse then pass to ventricle. Depending on their conduction speed, Tracts are called as slow tract and fast tract. When an premature atrial impulse reaches AV node, at that time one of the tract, usually fast tract, is still in refractory state, but slow tract is ready for conduction, hence it conduct impulse. By the time impulse reaches the other end, fast tract comes out of refractory state. So impulse not only passes down into ventricle but also conducted retrogradely in fast tract. By the time impulse reaches the other end, slow tract comes out of refractory state. So impulse is conducted retrogradely into atria and also conducted in slow tract in antegrade direction. And cycle continues and convert AV node to pacemaker, sending repeated impulses to atria and ventricles. In typical AVNRT, antegrade conduction occurs through slow tract and retrograde conduction occurs through fast tract. So in typical AVNRT, atrial and ventricular activation occurs almost simultaneously. Most of the time, P waves are embedded in QRS complexes, but sometimes occurs just after QRS complexes. As atrial activation vector is directed away from positive pole of inferior leads, there are inverted P waves just after QRS complexes, which can be confused as S waves. Hence, they are also called as pseudo-S waves. Lead AVR and lead V1 may have upright P wave just after QRS complexes, which can be confused with R' wave. Hence, it is also called as pseudo-R' wave. Rhythm in typical AVNRT looks like this. If we look closely, PR interval is greater than RP interval and RP interval is usually less than 70 milliseconds. RR interval is 8 small boxes long and it is constant. So rhythm is regular and heart rate is 1500 divided by 8, that is 188 beats per minute. Inverted P wave can be seen distinctly in lead V5. RP interval is shorter than PR interval. There are inverted P waves just after QRS complexes in lead 2 and 3. Similar waves are also present in lead AVF. This looks like S wave, hence also called as pseudo-S waves. There are upright P wave just after QRS complexes in lead AVR, lead V1 and V2, which can be confused for R' wave. Hence, they are also called as pseudo-R' wave. All these features are suggestive of typical AVNRT. On arrival of premature atrial impulse, if antegrade conduction occurs through fast tract and retrograde conduction occurs through slow tract and forms a re-entry loop, then this is atypical AVNRT. In atypical AVNRT, antegrade conduction occurs through fast tract and retrograde conduction occurs through slow tract. As with typical AVNRT, atria are activated in retrograde direction. As retrograde conduction occurs through slow tract, atrial activation is slightly delayed. Hence, there are inverted P waves in inferior leads in atypical AVNRT also. But P waves occurs well after QRS complexes. As P wave is delayed in atypical AVNRT, RP interval is longer than PR interval. For treatment of AVNRT, vagal maneuvers like carotid massage sometimes terminates the event. Adenosine is drug of choice. Dose is 6 mg IV bolus. If rhythm is not terminated, then 12 mg IV bolus is repeated. Calcium channel blocker like verapamil and diltiazem can also be used. Beta blocker like IV metoprolol is used specially if associated with hypertension or thyrotoxicosis. If associated with hypotension, DC cardioversion is treatment of choice. In atrioventricular re-entry tachycardia, re-entry circuit include both atria and ventricle. It occurs in person having accessory pathways of conduction. Baseline ECG may show sign of accessory pathway like delta wave in WPW syndrome. Sometimes this pathway conduct impulse in only one direction, mostly in retrograde direction. In such cases, baseline ECG is normal. In presence of accessory pathway, there is potential closed circuit through which re-entry can happen. Concept of re-entry is similar to that of AVNRT. When antegrade conduction occurs through normal conduction pathway and retrograde conduction occurs through accessory pathway, it is called as orthodromic AVRT. When antegrade conduction occurs through accessory pathway and retrograde conduction occurs through normal conduction pathway, it is called as antidromic AVRT. Orthodromic AVRT is a narrow complex tachycardia with rate ranging from 150 to 250 beats per minute. It is sudden in onset and termination. Baseline ECG may show sign of pre-excitation like delta wave in WPW syndrome. There are absent P waves. There are no pseudo S or R' wave. There is marked ST depression in multiple leads. When P wave is visible, RP interval is shorter than PR interval. But unlike AVNRT, RP interval is more than 70 milliseconds. Rhythm in orthodromic AVRT looks like this. This is baseline ECG of person having accessory pathway. There is delta wave which indicate WPW syndrome. In this ECG, RR interval is 8 small boxes long and constant. Hence, rhythm is regular and heart rate is 1500 divided by 8, that is 188 beats per minute. There is ST depression in multiple leads. P waves are not distinctly visible except in lead V4. If look closely, RP interval is shorter than PR interval. RP interval is definitely more than 2 small boxes long. This means RP interval is more than 70 milliseconds. All these features are suggestive of orthodromic AVRT. Antidromic AVRT is present when antegrade conduction occurs through accessory pathway. As ventricles are activated through abnormal pathway, QRS complexes are wide, and hence it can be confused with ventricular tachycardia. That's why this topic will be covered with ventricular tachycardia to understand the differences better. Treatment of AVRT is similar to that of AVNRT. For permanent cure of atrial tachycardia, AVNRT and AVRT, ablation therapy can be done. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.